Hello, everyone. Thank you for joining us for this patient education webinar. My name is Lauren Ogden. I am a patient advocate, and my history with pheochromocytoma started back when I was about 6 years old. I would always complain about the typical pheochromocytoma symptoms. I visited the doctor many, many times and was always dismissed of anxiety and told to just go home and relax. Fast forward to when I was 19 years old, I was finally diagnosed with adrenal tumors on both sides, totaling 11 pounds. Went straight to the hospital. They finally were able to remove them successfully. And for the next 5 years, I had recurrences on different parts of my body, like my lungs, my liver, and adrenal glands grew back, thyroids. So it was a pretty lengthy experience for me. For about 6 years of time then, no reoccurrences. They thought that we had cured any past Pheo issues. I decided to try and get pregnant and had to do IVF to obtain that. Nothing to do with my pheochromocytoma history, but we did IVF. I had some tests run during my pregnancy, and they had noticed, my doctors had noticed some changes in different hormonal levels that would significant be significant enough to show that I had possible pheochromocytoma come back. They did an MRI and found that the tumors had come back in my bones, my pancreas, and my liver. I had an MRI done during that time, and we figured out exactly what was going on, and our plan was to remove the tumors shortly after the pregnancy. We did an early C-section where my baby was born happy, healthy. She did not carry the genetic mutation, which is amazing and good news. And then aside from that, further down the road, there's my baby right there. She's almost 2 years old and extremely healthy and happy and the joy of my life and makes all of this worthwhile. But fast forward to when she was about 7 months old, we did a Zedra, which is a radiation treatment. It's a bit newer, but I know a lot of people in the pheochromocytoma world are a bit familiar with it. That was because the bone tumors could not be removed surgically. Now, fast forward to today, I still have a pancreas tumor that they think is active, which might have to come out surgically. The bone tumors are no longer active, still present, but aren't causing any effects to my day-to-day life. So things overall are great today, and I'm lucky enough to be able to attend this meeting and learn even more about pheochromocytoma and pregnancies, and hopefully shed some light for everybody else out there. I'm here today with Dr. Irina Bancos, who I will properly introduce in just a moment. But first, this program is brought to you by pheopara Alliance, whose mission is to empower patients with pheochromocytoma or paraganglioma, their families, and medical professionals through advocacy, education, and a global community of support, while helping to advance research that accelerates treatments and cures. Special thanks to Lantheus for making this webinar and series possible through an educational grant. Please sign up for our e-news and follow us on social media at pheopara. Please join us for our online monthly patient hangout via Zoom. Our next meeting is on Tuesday, April 6th, 4:30 Pacific Time, 7:30 Eastern Time. The link to register is at pheopara.org. We are also collecting feedback for patients who have been seen at University of Pennsylvania and the Huntsman Cancer Institute. If you have been seen at either of these institutes in the past year, please take our survey at pheopara.org. Your feedback will help us in evaluating these centers who have applied for a designation through our Center of Excellence program. Our agenda today will be Dr. Bancos, who has prepared our 25-minute presentation. She's pre-recorded it. After that, she will be live for a Q&A from all of you. Some of the questions that have been submitted beforehand, we will also ask questions submitted online via the chat function. Many people will ask variations of the same question, so listen carefully for the questions that are similar. Questions that are less case-specific are appreciated. A disclaimer is the information presented in the webinar is for educational purposes only and should not substitute this advice of your doctor and medical team because they have in-depth knowledge of your medical history and current situation. Dr. Irina Bancos is an associate professor of medicine and works in pituitary adrenal gonadal subdivision of endocrinology division at Mayo Clinic, Rochester, USA. She also serves as associate program director for the Endocrine Fellowship. Dr. Bancos has published more than 120 scientific articles and currently holds several grants in the field of adrenal disorders. She's also most notably a mom. Here she is.
Hello, my name is Irina Bancos. I'm an endocrinologist from Mayo Clinic, Rochester. It is a pleasure being here today with you. I'm going to talk about pheochromocytoma and paraganglioma during pregnancy for the next 20 to 25 minutes, and then I hope we'll have ample time for questions and answers. And I'll start by sharing my screen. Okay. And these are my disclosures. The outline for the next 20 minutes will be, number one, to review the take-home message from a recent international multi-center study in pheochromocytomas and paragangliomas and pregnancy. And I'll refer to the pheochromocytomas and paragangliomas as PPGL during this presentation. And then I'll end up by providing several recommendations and suggestions for women with or at high risk for PPGL and pregnancy. And then, as I've mentioned, we'll have some time for questions and answers. PPGL are rare neuroendocrine tumors that usually secrete catecholamines. And this catecholamine excess can be potentially severe with clinical consequences of hypertensive crisis, stroke, and even death. PPGL have a genetic association in around 40% of cases overall. But in young women or those women of reproductive age, the likelihood of genetic association is much higher than 40%. So given that PPGL are quite rare, when they occur in young women and when they occur during pregnancy, it's really an extremely rare situation. So there is no surprise that there was not much evidence in the PPGL in pregnancy until the recent large study which really organized multiple countries and centers to collect better type of evidence. Prior to designing the study, we did look at literature. We systematically reviewed literature, especially studies with at least 5 pregnancies included. And we saw that, again, only 65 women with 72 pregnancies in the studies. And we saw that only 11% of pregnancies occurred in women who knew about PPGL prior to conceiving. 64% of the women were discovered with PPGL during pregnancy, and 25% were discovered after pregnancy. The majority of women delivered through C-section, and surgery for PPGL was performed during pregnancy in around a quarter of all women. We've also been impressed by a high prevalence or risk of complications, maternal death 3%, or other maternal complications in 7% of all patients, fetal death in 13%, and other complications in 3%. And right away, we thought there was a significant selection bias because these numbers were much higher than what we would usually see in our centers and other adrenal centers around the world. There are some other limitations to that literature: small sample size, really unclear relationship to the time of PPGL diagnosis. It was unclear what type of delivery, C-section or vaginal delivery, would be advisable in women with PPGL. The timing of the surgery, should it be performed during pregnancy or after pregnancy? It was unclear whether alpha blockade therapy with doxazosin or phenoxybenzimide was effective. And overall, the predictors of unfavorable pregnancy outcomes, something that we can address as patients and providers, were unclear. So with this in mind, we thought, let's try to fill those gaps in knowledge. So again, prior to starting the study, we established the following 3 objectives. Number 1, we wanted to describe the characteristics, clinical course, and outcomes of women with PPGL during pregnancy. Number 2, we wanted to determine the predictors of maternal and fetal outcomes in women with PPGL. And number 3, to determine the best approach to management of PPGL during and hopefully before pregnancy. It was a huge effort. It was an international retrospective multi-center study of 28 countries across the world. We've included any patient with PPGL and pregnancy occurring between 1980 and 2019, meeting one of the following criteria: PPGL discovered before or at any time during pregnancy, or PPGL discovered within 12 months postpartum. And these were the countries and the centers that contributed. In the second column, you'll see the new data, the multi-center collaboration data. And in order to improve the quality of our evidence, we've also included all the publications with at least 5 pregnancies included. And this is in the third column under systematic review. So in total, we had 197 cases from the multi-center collaboration and 52 cases from the systematic review, totaling 249. 249 pregnancies that occurred in 232 patients with PPGL. Why the difference? Well, because 10 patients had 2 pregnancies with at least 1 pregnancy with unrecognized PPGL. 1 patient had 3 pregnancies during untreated PPGL, and 1 patient 6 pregnancies. Imagine that. So what did we find? The tumor size of pheochromocytoma and paraganglioma really varied. The average size was around 5 centimeters, but the largest was at 31 centimeters. The majority of women with PPGL during pregnancy had either single pheochromocytoma or Pheo, or single paraganglioma or PGL. But quite a few also had bilateral pheochromocytoma, multiple paragangliomas, or even metastatic paraganglioma. 95% of women with PPGL in pregnancy had a functioning PPGL, meaning they would produce catecholamines or adrenaline. How much adrenaline? Well, the majority, produce quite a bit. So 10 times upper limit of normal range, that's how we try to classify the severity of adrenaline excess. So as you see, half had very high adrenaline in either urine or blood, or metanephrines, I should say. Only 62% of our patients were actually tested for genetic association, either before pregnancy, during pregnancy, or after pregnancy. And the most common genetic associations were RET, SDHB, VHL, and SDHD. We also had a variety of other genetic associations. So here's the data. 15% of all women in our cohort were actually diagnosed with PPGL before pregnancy. So they were well aware of the PPGL when conceiving. And for most of these pregnancies, pregnancy was actually planned. 54% of all women discovered PPGL during pregnancy, most commonly because of symptoms or maybe incidental ultrasound findings and so on. And a third, 31%, were discovered with PPGL only after pregnancy. Now, looking at women discovered during pregnancy, most were discovered quite late, so at median gestation week of pregnancy of 24, but anywhere between 2 weeks and 38 weeks of pregnancy. For those discovered after pregnancy, it was usually around 6 weeks after delivery, anywhere up to 1 year after delivery. And only in retrospect, it was clear that some of those symptoms of catecholamine excess during pregnancy were due to unrecognized pheochromocytoma or paraganglioma. Out of these, only 231 were functioning PPGL. And we're going to look only at functioning PPGL because no woman with non-functioning PPGL had any adverse outcomes. So really, we're looking here at adverse outcomes only due to catecholamine excess. So again, 15% of women discovered with PPGL before pregnancy, 52% during pregnancy, and 33% after pregnancy. Only 63% of all women discovered before during pregnancy received alpha blocker during pregnancy. And 25% of these women had surgery during pregnancy to remove that PPGL. So this is our cohort. Now let's see what happened to this cohort of patients. So looking at baby outcomes, there was a 9% overall adverse outcome rate. But it was 0% when PPGL was actually discovered before pregnancy was planned or occurred. 8% for babies and 3% for mothers. Complication rate occurred when PPGL was discovered during pregnancy. And the highest rate of complications happen in women who did not know that they had PPGL during pregnancy, 13% for babies and 19% for women. So overall, combined rate was 14%, because usually a complication would happen to both mom and baby. So this is what happened to overall to those 231 women. We've predefined several variables, several factors that we thought would be important to assure a safe and healthy pregnancy in a woman with a functioning PPGL. We thought that the timeline for diagnosis with PPGL before, during pregnancy would be important. Degree of catecholamine excess was a second factor we thought would interfere with pregnancy. Location of PPGL, for example, abdominal or pelvic PPGL were actually could be exposed to contractions or pressure from the uterus. We thought that was important. Metastatic PPGL, another thing we looked at. Presence of genetic predisposition. Therapy during pregnancy, such as alpha-adrenergic blockade or surgery. And then we looked at type of delivery, C-section or vaginal delivery. So let's look first at timeline. When we looked at patients who knew about PPGL prior to conceiving, again, a minority, only 15%, we found that absolutely no complications occurred in these pregnancies. And we suppose it was because of appropriate planning for therapeutic procedures before pregnancy. So, for example, a large number of these women actually had metastatic disease. So possibly some local therapies were administered prior to pregnancy. And maybe there was also some selection bias, meaning that women with stable metastatic disease were much more likely to actually plan pregnancy and proceed with that. Another huge factor for this category of people was early initiation of alpha-adrenergic blockade before or during pregnancy. So these women were very well treated and very well monitored. And overall, this category of patients reflected really a higher level of expertise in monitoring from the medical provider and self-care from the patient. Looking at those diagnosed during pregnancy, now, this category did much better than those who were not recognized to have PPGL at all during the pregnancy. But still, these patients had 8.3 times higher risk of complications when compared to those diagnosed before pregnancy. And it is because this late diagnosis during pregnancy led to later or inadequate or even absent therapy during pregnancy. As you see, not all of these patients were treated with alpha blockade, and complications did not occur in anyone on optimal treatment in this category. So let me summarize the findings for you. As far as timeline for diagnosis of PPGL, definitely knowing about PPGL before going into pregnancy was extremely helpful. But even if it doesn't occur, learning about it as early during pregnancy as possible is giving an opportunity to both patient and the medical provider to come up with a plan that would be safe to continue pregnancy. The second factor, degree of catecholamine excess, we definitely did see that the higher were the catecholamine levels, the more likely it was for adverse effects to occur. Location of PPGL, indeed, abdominal and pelvic PPGL were associated with higher adverse events. However, this was not the case for any patient diagnosed before delivery. So that was the case for patients not recognized with PPGL until after baby was born. But again, when a physician and the patient knew about PPGL anytime before delivery, we did not find that was an important factor. We've been surprised that metastatic PPGL as just one single category was actually protective. So patients with metastatic disease did not have any complications related to catecholamine excess, either to a baby or to the mother. And we think that occurred because of a proper planning. Another explanation for that would definitely be low-grade metastatic disease, like, for example, bony metastasis or liver metastasis that are quite stable. And even if functioning, the catecholamine excess is not of the highest degree. More importantly, these patients were started on alpha-adrenergic blockade before pregnancy. Another protective factor was presence of genetic predisposition. And we actually think it's not necessarily that a particular genetic association is protective, but because women with known genetic predisposition are much more likely to be discovered with PPGL at a earlier course of pregnancy or even before pregnancy, and hopefully also at a much smaller tumor size. And I think overall, this is why this came out to be sort of like a protective factor. The most important factor of all was, well, other than timeline for diagnosis, was alpha-adrenergic blockade. Presence of alpha-adrenergic blockade of at least 2 weeks prior to delivery was protective from any adverse outcomes during delivery. Of course, if optimal, as far as dose and duration. So duration, we thought 2 weeks was optimal based on what we found in our study. However, of course, those patients need long-term alpha-adrenergic blockade if it's a functioning PPGL started before therapy, before pregnancy. Surgery actually was not a significant factor in decreasing or increasing risk of complication. There was no effect at all of antepartum or before delivery surgery. And finally, when we looked at C-section versus vaginal delivery, that again did not have an effect on complications. However, I think some caution is needed here because there was some selection bias and why some of the patients who medical team knew about PPGL were chosen for C-section versus vaginal delivery. Of course, there could have been some other factors leading to C-section choice or personal preference leading to either C-section or vaginal delivery choice. So the decision on type of delivery really needs to be individualized based on all the above factors. Looking at delivery, C-section or vaginal, most patients in our cohort did deliver through C-section, 70%. And those patients tended to have a higher degree of catecholamic excess and higher likelihood of having abdominal or pelvic PPGL. And in the vaginal delivery category, there was just a lower degree of catecholamic excess and slightly more likely abdominal pelvic PPGL, 64%, but not as much as in C-section category. Otherwise, these groups did not differ as far as maternal age, tumor size, rate of metastatic disease, and these two groups had the same rate of complications, whether it was C-section or vaginal delivery. So the bottom line here, vaginal delivery can be safe if performed on very well-selected patients with a good understanding of what this means and under good alpha-adrenergic blockade. So to conclude here, recognizing PPGL before delivery is key. Patients with metastatic PPGL can have a safe pregnancy if under close monitoring. Surgery during pregnancy can be safe, but may not be necessary, especially if extra-abdominal PPGL. So the decision on surgery during pregnancy needs to be individualized to a specific situation and only with optimal alpha blockade therapy. Importantly, alpha blockade prevents adverse outcomes, especially if optimal as far as duration and dose. And choice of C-section versus vaginal delivery is again individualized. So an informed discussion, decision-making should be there between the patient and a multidisciplinary team, which includes endocrinologist, anesthesia, OBGYN. And I hope this is available to any woman with PPGL and pregnancy. I would like to move on to several recommendations or suggestions for preconception planning in women at risk for PPGL. In those with known germline variant associated with PPGL, such as TRAT, neurofibromatosis type 1, von Hippel-Lindau, SDH, biochemical testing is recommended, as well as cross-sectional imaging, preferably MRI, prior to planning pregnancy. And when I say recommended here is really based on expert opinion and some data. In women with personal history of PPGL, definitely biochemical testing for catecholamine excess is needed on a yearly basis anyway, but especially before conception planning. Cross-sectional imaging, preferably MRI, should be considered. And if not yet done, genetic testing for germline variants should be performed. In a woman with family history of PPGL, for example, first or second degree relative with PPGL, biochemical testing and genetic testing for germline variants should be strongly considered prior to pregnancy conception. The second slide here, as far as recommendations go, is all about medications, timing, and treatment goals for PPGL in pregnancy. So this really applies only to women who have PPGL and are pregnant or planning to be pregnant. Alpha-adrenergic blockers should be started at the time of PPGL diagnosis. And this is really talking about PPGL, which is impossible to remove before pregnancy. Titrate to low normal systolic blood pressure, and balancing dosing with side effects to find a maintenance dose is advised. We also emphasize increasing fluid and sodium intake, and we intensify therapy at 36 weeks to prepare for delivery if needed. Beta-adrenergic blockade. We usually start that after at least 1 week of alpha-adrenergic blockade, and we add it only if needed to control heart rate. We titrate it to the heart rate of 80 to 90 beats per minute. Finally, calcium channel blocker. We start after titration of alpha-adrenergic blockade for 2 to 3 weeks, and we add this medication only if persistent hypertension despite adequate alpha and beta adrenergic blockade. We'll talk about the Q&A live. And I just wanted to thank you for your attention. I would like to include my email here and Twitter. I would like to acknowledge all collaborators from the International Multicenter PPGL and Pregnancy Work Group. I was just impressed by this group of people who take great interest and are passionate about pheochromostomas in general, but especially in young women who may also be pregnant. I also like to thank William Young and Lucinda Gruber, who worked with me on the recommendations and in the review that will be soon published, pheochromostoma and paraganglioma and pregnancy in New Era. And some of the slides that you've seen are from this review. Thank you.
Thank you for that. That was some really great information. To start off our Q&A, we have our first question here. It says, is there a correlation between pregnancy and tumor development? Is there any evidence that pregnancy triggers an SDH mutation to activate?
Yeah, that's a good question. Nothing that we know about. Certainly, it's such a rare occasion that the studies are just impossible. But there is nothing in the pathogenesis of tumor that would show that estrogen or pregnancy or fertility treatment would actually prompt that tumor development. I think that's kind of where we are right now.
Perfect. Is there any research done that shows the effect on an undiagnosed through while the mom was pregnant and long-term effects on the baby?
Yeah, again, very little information out there. But I do want to point out a few things which I think may answer this question a bit differently. So one is placenta actually has an enzyme which metabolizes or gets rid of adrenaline. And based on very little evidence, it seems that actually very little portion of adrenaline itself gets to the fetus, maybe around 10% or so to the baby. So the adrenaline itself does not seem to be causing problems with baby development, again, based on very limited data. But mother's hypertension because of adrenaline, because of catecholamine excess, could affect baby development. Mainly because if we have these episodes of hypertension, most of the data here comes from preeclampsia, which has nothing to do with pheochromocytoma, but those women also have high blood pressure. So the data coming from that cohort shows that maternal hypertension, especially severe hypertension, uncontrolled hypertension, decreases the vascularity or the delivery of blood and oxygen to the baby. And that may lead to the prematurity and to the intrauterine growth retardation. And it is possible that this also may have some sort of long-term outcomes. But as of now, at least me as an endocrinologist, I'm not really aware of those in great detail, at least. So that's probably emphasizes the fact that we need to control hypertension in the mother. for whatever reason, whether it's due to pheochromocytoma or preeclampsia.
Thank you. Someone wrote, I had a few about 10 years ago and had genetic testing done then. No mutation was found. We would like to have a baby. Should I get genetic testing done again?
Yes. So first of all, the second thing, should someone like that get into genetic testing again? And the answer to this is yes, because genetic testing has improved significantly in the last 10 years. So definitely for someone with high likelihood of genetic association, such as pheochromocytoma at young age or bilateral pheochromocytoma, and negative genetic testing in the past, should reconsider genetic testing every 5 to 10 years. Now, the second thing is whether there is a known genetic association or not, anyone with history of PPGL before should definitely consider screening for presence of pheochromosomal paraganglioma before conceiving. And that should be done certainly by some sort of biochemical test, probably 24-hour urine for catecholamines and metanephrines would be the best here. But secondarily, if that risk is high, one may also consider MRI of abdomen and pelvis at least.
Thank you. What specialist should I have involved? I am pregnant with a functioning Pheo.
Yes, so certainly an adrenal endocrinologist who should be kind of the primary physician at this point, who hopefully can recommend a good OBGYN person who is experienced in this type of higher risk situation, who can absolutely assure optimal treatment during pregnancy and have that individualized conversation of what exactly is needed for this particular situation. And depending on where you are, just making sure that anesthesia team is available for whatever type of delivery you're planning. So what I mean by that is that even under optimal alpha blocker therapy, it's useful to have anesthesia team very much experienced with what's needed for catecholamine release, for example, during pheochromocytoma surgery. And I would recommend it as early as possible in the pregnancy.
Thank you. I'm just about to go through IVF, and depending on, I have a genetic mutation. I've heard stories of tumors returning after getting IVF treatment. Does IVF increase the risk?
Yeah, so nothing that I found or personally experienced. So obviously science changes all the time, but at this time and age, I would be more inclined to think that it's whenever this is described or shared, it's more coincidental. So I just don't quite see what exactly in this fertility treatment could actually bring it on. You know, sense like that. Maybe a few years from now, we'll find out something different. But as of now, there is no relation to the best of my knowledge.
Perfect. I was pregnant with a Pheo and went through successful pregnancy and now have a healthy 2-year-old. I don't know her genetic status. When should we get tested if I have an SDHB?
Okay. So if the mom has a known mutation, let's say SDHB, then I would say, especially for SDHB, it's probably a good idea to start testing early. How early? As early as possible. I would say probably at least around 5 years of age. If the mom does not have a known genetic association or known genetic mutation, I would recommend for mom to be tested first before testing the child. And only if we find the genetic mutation in the mom, then proceed with genetic testing in the child. To answer this just a bit differently, depending on the genetic association, the risk of paraganglioma and pheochromocytoma in the baby is different. For some of the genetic mutations, we should start screening, case detection for the child at a younger age. For others, we don't have to start very young because we know that pheochromosomas and paragangliomas may not occur until maybe teenage years or early adulthood. And this is why it's a bit difficult to answer this question with a standard answer.
Perfect. Would you say that it's important to get children tested as a baby and further along as they grow older in age, from like a newborn status to say 5 to 10 years old, get tested again if they originally were negative for the mutation?
So it depends on the situation. Just because this whole webinar is on pregnancy in Pheo, I'm assuming mom has pheochromocytoma. And I think, as I've mentioned with my last answer, very much depends on what type of genetic testing mom has. Personally, I would test mom every 5 to 10 years rather than the child, at least during the childhood. Now, I also recommend close clinical follow-up, physical exam, and maybe even testing for metanephrines of a child who may be at risk for PPGL, but unclear genetic status. It's just a different way to be a bit on a cautious side there and to not miss a potential pheochromocytoma.
Thank you. Also, everyone, feel free to ask questions in the chat. We will get to them in order. So our next question here, a general Pheo question. Can you have a normal metanephrine levels if you are not currently having a Pheo episode?
Yeah, so that's another question which has several layers as far as my answer. So first of all, there is something we call biochemically silent pheochromocytoma. And what that means, that metanephrines in either urine or blood are normal. But we clearly know that this person has pheochromocytoma or had pheochromocytoma. Let's say it was removed, and in retrospect, we know it was a pheochromocytoma. This happens in two situations. The first situation for this biochemically silent pheochromocytoma is when we discovered at a smaller tumor size, where the production of catecholamines from this tumor is just not above the threshold where we have our normal ranges for metanephrines and catecholamines. So should this tumor be discovered at a later stage, when let's say it's not 2 centimeters, but it's 6 centimeters, I would say it's very likely that the testing for metanephrines would become positive for those smaller tumors. So this is situation number one. Situation number two for this biochemically silent pheochromocytomas would be just really those tumors are not producing any catecholamines. So they can be 10 centimeters in size, but they're just non-functioning. And those, I would say, are rare, but certainly possible. So this is one way to answer this question. I do want to provide some different insight, though, as well. So we, at least in our cohort of patients, outside from pregnancy, we have seen patients with normal metanephrines in urine or blood and clear-cut pheochromocytoma paragangliomas who complain of episodic symptoms of hypertension or palpitations or anxiety attacks, whatever else can present to that, but their testing is within normal ranges. So we think, or I think, that it's not necessarily that metanephrines are different during episodes, because those tumors are always capable of that adrenaline production, and metanephrines are long-acting metabolites which should be positive, should be elevated even outside those episodes of pheochromocytoma attacks. I think it's just a case of the fact that it's still abnormal, this adrenaline production. And the person is very sensitive to that adrenaline release, even if it's under diagnostic cutoff. I would say it's, again, uncommon, but certainly is possible. And in that cases, ultimately, we rely on imaging characteristics and provide the same treatment, which is surgery. I hope this answers this question.
Thank you. Next question. I had a large 16-centimeter para removed while 5 months pregnant in 2019 and had a C-section. We were thinking about having a second child. Would you advise to ask for testing to be run again to make sure there are no issues? And would you think it's reasonable to request a C-section again?
So for the first question, absolutely, I would advise to be tested. I think it's absolutely important to make sure that in a case like that, there is no other pheochromocytoma or paraganglioma, and the pregnancy can be started in the safest way possible. And that probably could be done, again, both with urine testing for catecholamines and metanephrines, as well as possible MRI of abdomen. Again, depending on other risk factors there. Now, the second is for C-section. So as I've presented from this, from our data, I think that from the pheochromocytoma point of view, assuming there is no pheochromocytoma, which hopefully could be managed before pregnancy, there is no really indication for C-section because of history of pheochromocytoma. There may be indication for repeated C-section for other reasons, which I'm just not qualified to comment on. But I guess there is no strong indication for C-section because of this history of pheochromocytoma.
Thank you. You mentioned in the presentation that 95% of PPGLs in your study were functioning. Is that the same as in a normal population?
And I'm assuming normal, like all comers, anyone with pheochromocytomas and paragangliomas. I actually think that the number of non-functioning tumors is much higher in the all comers, mainly because most of the head and neck paragangliomas are non-functioning, so those are quite common. Again, we have not included those in our analysis. We've excluded every non-functioning tumor, but I also wonder if those non-functioning paragangliomas just occur a bit later in life. Or maybe are less likely to recognize during pregnancy. So to answer this question, again, I think 5% of non-functioning pheos and paras that we've seen in our study is lower than what we would usually see in all comers, men and women at any age with pheos and paras.
Thank you. Can you talk a little bit about the NF1 mutation? Does it affect kids more than it affects adults?
So, neurofibromatosis type 1 is an autosomal dominant genetic mutation, which with variable penetrance. So what that means that you're born with this. So, and it's 1 in 2 chance that you're going to inherit a mutation if one of your parents had NF1. Now, how much it would penetrate and would, show yourself, that's a bit of a different question, especially when it's related to pheochromocytomas. The overall risk of pheochromocytomas in someone with NF1 is around 5%. So not as high as with some of the other genetic mutations associated with pheochromocytoma and paraganglioma. And compared to some of the other more common ones, for example, von Hippel-Lindau syndrome, VHL, or MEN2, NF1 pheochromocytoma related to NF1 does present at a slightly older age and less likely to be seen in younger women who are pregnant. So that's one. The second one, having said that, anyone with NF1, or let's say young woman with NF1 wanting to start a family should get tested for potential pheochromocytoma. In this case, it's usually unilateral pheochromocytoma, though bilateral pheochromocytomas are not that uncommon with NF1. And metastatic disease also has been described with pheochromocytomas NF1. So absolutely, even though there are no recommendations in place, to the best of my knowledge, within NF1 world, I always recommend my patients with NF1 to have a full workup for pheochromocytoma before conceiving.
Thank you. Did you say there are any risks in pregnancy even after a pheo and para have been removed?
Yeah, so the main risk of pheochromocytoma during pregnancy, or unrecognized or untreated pheochromocytoma during pregnancy, is really catecholamine excess. So if someone has history of pheochromocytoma, which was removed and catecholamine excess is no longer present, the risk obviously it's not there from that point of view. Now, of course, depending on why that person had pheochromocytoma and what other syndromic features of, let's say, neurofibromatosis or VHL or anything else is going on, there may be a higher risk because of that, but clearly not because of catecholamine excess. So I guess the short answer is no.
Thank you. Should everyone who is diagnosed get genetic testing?
Yes. See, that's easy to answer. Okay, let me provide a bit of a longer answer. There are all kind of algorithms. Like, for example, if you're old and if you had just unilateral pheochromocytoma, and if there is no family of pheochromocytomas or other syndromic features, you're less likely to have a genetic mutation. So why get tested? And this is true. This is true that the likelihood of genetic association is higher if it's bilateral Pheo, if it's a younger person, certainly if there is a family history. But I do think that in this day and age, knowledge about this genetic association is very helpful, not only for the patient, him or herself, because knowing someone's genetic mutation allows me to provide individualized recommendations for monitoring for future pheochromocytomas. But there's a second reason, and that's for blood-related family members, which if that older person does have some sort of genetic association, he or she could share it with all the other, maybe younger members of the family, for them to decide whether they want to get tested. Because everyone, even people with the same genetic mutation, have different ways that they actually demonstrate their disease. Within the same family, we can have someone who presents very late in the, in like an elderly age with very only one small tumor versus another family member with metastatic disease at age 30. So this is my long answer for that.
Thank you. I have a son with metastatic PGL and SDHB mutation. His father also has SDHB mutation. His brother does not. Can the brother who does not have the mutation pass it on to his offspring?
Not for SDHB. So SDHB is, again, autosomal dominant disease. So it means that every child has 1 in 2 chance to inherit it. And if you did not inherit it, this is it. You don't continue to pass it to your family, to your kids, and so on. So no worries about the child who was tested negative, basically.
Thank you. Do you have a preference for deoxazotine or phenoxybenzamine during pregnancy? And would you say that it has any effect at all on the child that the mother is carrying?
Yeah, so unfortunately, extremely few data on this. I have a preference for doxazotine because it's less expensive, it's as potent, it can be titrated a bit better, and it's not as long acting, which means that it's a better choice for around surgery or around delivery time. I did find just a bit of data showing that doxazotine does pass towards baby through, from mom, but at a lower concentrations. And as of now, what we know, there is no adverse outcome of doxazotine on baby development. Obviously, I don't foresee that human studies will be ever done in this. But from what we know from animal studies and what we know about human pharmacology, this seems to be the case.
Thank you. I have an SDHB and was diagnosed with a not-secreting para-glomerulus jugular at age 20. I know they don't see these tumors passed and activated often by women, but what are my chances of passing it along?
So I'm just to clarify, that's SDHD.
Yes, sorry.
Okay. So so yeah, I guess maternal paternal imprinting and so on here. So it's not 100%, but you know, as a baby from a mom with SDHD is much less likely to develop the disease, but is just as likely to inherit the mutation and to pass along to his or her baby. So I will not go into details of why that is, but ultimately it's genetic testing that needs to be performed in the baby to understand whether that baby carries, or hopefully an older adult carries mutation or not, to decide on whether his or her kids should be tested.
Thank you. Is there data on women who develop other issues after pregnancy, like fibromyalgia?
Yeah, so well, there are in general some data that after any pregnancy, there are some issues which can develop in women for multiple different reasons. And that's change in lifestyle, but also pregnancy is an interesting physiological state which may trigger certain things. But we actually don't know whether having pheochromocytoma itself during pregnancy can lead to, let's say, fibromyalgia. Certainly, any type of stressor can lead to fibromyalgia. And pheochromocytoma is a stressful situation to have. So who knows? Certainly, it's possible. But to answer this question a bit differently, in my patients with pheochromocytoma, I have to say that I just don't see it very often. New onset fibromyalgia after pheochromocytoma surgery.
Thank you. As we close the session, can you just restate your findings, especially the part on, well, just let's close it out, I guess, at this point. Thank you, everyone, for joining us today. I have learned so much, and going through it myself and talking with Dr. Blancos about pregnancy and pheochromocytoma and the effects that it can have on us. It's so great to be moving forward and finding answers. I know when I was going through it, even just a couple years ago, there wasn't as much research as there has been done now. I'm excited to have my baby with me who's healthy and be able to look towards the future, and that I'm not in concern of her having that genetic mutation any longer. I'm excited that we have created this community amongst everyone that women can reach out to one another and share their findings and their experiences that they've had while pregnant and while finding pheochromocytoma, and hopefully be able to cope better and find a cure for it eventually. My baby right now, my husband just put the monitor down next to me. She's sleeping soundly. And I'm just excited for everyone to be able to learn and grow and share their findings with their doctors to hopefully be able to have that perfect pregnancy and their babies shortly. Thank you so much.